Good morning. Welcome to the Gordon Lecture. Dr. Gordon was the first fully trained colorectal surgeon in Canada and devoted his practice solely to the practice of colorectal surgery. He was the first director of colorectal surgery at the Jewish General Hospital. He was the founding president of the Canadian Society of Colorectal Surgeons and the first non-American to serve as president of the American Society of Colon and Rectal Surgeons, as well as the American Board of Colorectal Surgery. He published numerous reference articles and textbooks, which fellows use to study for their board exams. And in honor of his contribution to colorectal surgery, and his inspiration for many of us to become colorectal surgeons, we have honored this contribution as the Gordon Lecture. This morning, we are honored to have Dr. Erin Kennedy, who comes to us from the University of Toronto, where she is head of general surgery at Mount Sinai Health and deputy chief of surgery there as well. She is a professor of surgery as well as a professor of health policy management and evaluation at the U of T. She did her colorectal and general surgery training at University of Toronto and earned her PhD during this time as part of the physician scientist program. She is the current GI lead in Ontario Cancer Canada, and her primary interests include management of rectal cancer as well as quality of care. She has been involved with several multidisciplinary led studies in an effort to improve synaptic reporting of MRIs in rectal cancer, and has succeeded in doing this in Ontario. She has also led CIHR investigations into de-escalation of the management of rectal cancer, and we heard some of that yesterday when she lectured to us on the Quicksilver trial. She's also had CIHR grants for the investigations of bowel preps, and that was just recently published. And today she's going to speak to us about a multidisciplinary investigation into managing the gaps in our knowledge and management of rectal cancer. Her title of her talk is 50 Shades of Quality, Lessons Learned from the CPAC Cancer Project. And I must say that we were thrilled to have her with us yesterday and last evening, where she just interacted seamlessly with our fellows and our residents who really enjoyed her company. So please join me in welcoming Dr. Kennedy as the 6th annual Gordon Lecturer. Dr. Kennedy.
Do this thing.
Mm-hmm. Great. Well, thank you very much, Dr. Vasilevsky, for the kind introduction. I'm really excited and honored to be giving the Philip Gordon Lecture today. Let me just see. There we go. Oh, perfect. Thank you. I have to say I didn't know Dr. Gordon particularly well. I think I met him one time, and I'll talk a little bit about that. But I probably know him a lot as how you know him, as the author of our Bible of colorectal surgery, Gordon and Nevatvangs, and as the co-founder of the Canadian Society of the Colon and Rectal Surgery in Canada. And I actually, when I did meet him in person, he was actually receiving an award from the CRCRS for distinction. And it was in about 2015. And I can remember that when he did his acceptance speech, it was about 40 minutes long. And I was like, man, can this guy ever talk? And, but the one thing that really stood out about it was that he still, sort of at that late time in his career, was so passionate about colorectal surgery. And it really shone through when he spoke and did that talk. And when I was sort of looking, preparing for this talk, I came across one of his quotes that really resonated with me. And I'm actually going to read it if I can. It's sort of hiding in my screen. But during my years in practice, I placed many patients on protocols. I spoke to the patients, but in retrospect, I do not have a very, I'm going to move this, sorry. Yeah. I did not do a very good job. This was not because I had no compassion for the patient, because I did. This was not because I was rushing off to the next patient, because I wasn't. This was not because I was uncomfortable with the disease, because I wasn't. This was simply because I was not in their shoes. And the only person who can understand what the side effects are is the person who experiences them. The admonition to walk a mile in someone else's shoes means you must understand his or her experiences, challenges, and thought processes. In effect, it is a reminder to practice empathy. And I just thought this was a really important quote, because I think, you can be a really good technical surgeon, but without empathy, you can't be a master surgeon. And I just thought it really just stood out to me as a really important quote, and as something we need to think about in surgery. And I think today, the Gordon Day, as well as the lecture, is such a great way to celebrate his legacy. And really, I wanted to point out that everyone here in this program, I think, is his legacy. And, it really shows through how you all work together. And you really do have a world-leading and world-class program with a lot of international leaders. I also just want to take this time in June just to sort of reflect and congratulate all the graduating residents and all the graduating fellows. Congratulations. It's a great milestone to finally finish and move on to the next part of your career. And I just wanted to say that I really had a good time spending the day with the residents and fellows yesterday. I just wanted to also say how impressive all of your presentations were, and how well you did on the mock orals. And I was very appreciative to be a part of your graduation ceremony. So thank you. Okay, now getting on with the talk, I thought I just needed to explain a little bit about why I picked this title, 50 Shades of Quality. And first of all, I wanted the title to be a little bit provocative so that people would be a little bit enticed or interested in actually coming to the lecture. But really why I picked this title is it really reflects sort of my experience and my thinking, how it's evolved over quality improvement. I thought when I first sort of delved into quality improvement, it was quite simple, easy peasy, everything's black and white, no problem. And as I started sort of experiencing or doing a little bit more quality improvement, probably like a lot of you in the room, you realize how complex it actually can be, and all of the layers and all of the different shades of gray and uncertainty that come up as you get sort of more and more involved in it. And I wanted to talk about the Canadian Partnership Against Cancer, Rectal Cancer project, just because it was a very meaningful project to me. It was one of my first multi-year grants that I got as a principal investigator, and it was one of the biggest budgets I'd had, over $1 million. So it was a very important and special project to me. And I just wanted to sort of go over sort of the things that we learned when we did this project. And I think although it's a rectal cancer project, I think it's got a lot of parallels with any malignant or benign multidisciplinary disease. And sort of it has a lot of application to other areas as well. So over the last 2 decades, there's been significant improvements in the outcomes of rectal cancer care. And that's mostly been due to increasing use of these strategies on this slide: multidisciplinary case conference, pelvic MRI, use of preoperative chemoradiotherapy, total mesorectal excision, and pathologic assessment using the Quirk method. And although these strategies have been shown to improve care and are recommended in published guidelines, we know that the implementation of these strategies vary considerably across North America and Europe. And this unwanted variation suggests that the best evidence is not always being implemented and represents a quality gap. And there's been really little research on the impact of knowledge translation interventions to reduce this variation. So not surprisingly, we did a crude survey of 8 high-volume hospitals across Canada. And, what we saw, let me just see if I got my pointer, is that, only 2 hospitals across Canada at high-volume centers were actually doing rectal cancer MCC routinely. And while all of the hospitals reported doing pelvic MRI, only 2 of them reported using a specified protocol or a synoptic MRI report. And only 2 centers reported using the Quirk method for pathologic assessment. None of the centers at the time that we did the survey were actually using all of these strategies routinely. And it seemed when we did the survey that none of the hospitals were able to do it sort of with complete fidelity to the optimal practice. So this really represented an opportunity, and sort of our idea when we talked in our group of colorectal surgeons was that, wouldn't it be great if we had a multidisciplinary Canadian community of practice to improve the quality of rectal cancer care? And could we do this by sharing best practices and helping each other to minimize the unwarranted variation, to identify gaps in care and implement strategies to close those gaps? And this idea sort of came to fruition or came true when we got the CPAC, or the Canadian Partnership Against Cancer funding, to do this project. And again, really the idea was we would develop this Canadian community of practice. We would sort of look at processes of care, find the gaps in processes of care, and then implement strategies to try to close these gaps. And I'm sure you're all aware, but a community of practice are groups of people who share a concern, a set of problems, or a passion for a topic, and who deepen their knowledge and expertise in this area by interacting on an ongoing basis, by sharing information, by learning from one another and helping each other achieve common goals. And there's actually been a Cochrane collaboration that has shown that use of community practice increases outcomes or improves outcomes by up to 17%. In terms of quality improvement, one of the main or most prominent, I think, models of quality improvement is the Donabedian model that looks at structures, processes, and outcomes, and then defines best practice in terms of these structures and processes of care, and then measures outcomes, identifies gaps in care, and then implements strategies to improve those structures and processes. And as you can see, I've put that red arrow there. It's a sort of continuous and iterative process. You do it over and over again to sort of continue to make small improvements over time. So in terms of our CPAC rectal cancer project, it was a 3-year project. And our first year was really a planning year. And in that year, as a community of practice, we decided what process indicators we were going to select and measure over a 2-year period later down the road. And we also, when we picked those indicators, wanted to identify some tools that we could use to help us sort of improve our uptake of those indicators. And then in the second and third year, we had a recruitment phase where we recruited patients with stage 1 to 3 rectal cancer who were having TME surgery at the participating centers. And we followed the uptake of those selected indicators over time. And we provided audit and feedback to each center. So each center could see their individual results as well as how they were doing compared to all the other centers every 3 months. And that was sort of that was the recruitment phase of the study. And the end products of the study were really to hopefully have a multidisciplinary model to improve the quality of care for rectal cancer, and that the participating sites in this study would be able to take the lead and disseminate the model in their respective provinces, and also to develop a well-coordinated community of practice where we could continue to work together on projects, including grant capture and trials. So we did, at the start of the study, convene a community of practice. And this was a multidisciplinary community of practice from 8 different centers. And from sort of west to east, it included centers from BC, Alberta, Manitoba, Ontario, Quebec, and Nova Scotia, and McGill was one of the participating sites. And from each site, we had a radiologist, a radiation oncologist, a surgeon, and a pathologist who participated and were sort of the site leads for their own center. And we came together in a workshop and we worked to develop and finalize the project. And the community of practice itself was actually part of the knowledge translation intervention of this project. So we did a modified Delphi survey of the community of practice to sort of pick the process indicators we wanted to measure over the course of the project. And we did this as an in-person workshop after the survey. We discussed each specific item. We had about 70 items to start off with. We evaluated the clinical importance of each of the items. And then we were pretty critical about the ability to measure this item, that it had to be easy to measure, easy to abstract from the medical record. And we wanted to pick things that we thought were going to be pretty accurate as well. And it wasn't meant to be an exhaustive list, but a meaningful and realistic list. And at the end of the session, we had an anonymous vote by all of the members of the community of practice, by all of the participants to either include or exclude items. And we only kept items that had over 90% agreement. So this is the list of the indicators. It's a short list. There's 12 indicators. I'm not going to read them all out, but I put 2 little stars beside synoptic OR report and MCC presentation because I have a little stories for each of those. So first of all, the synoptic OR report was an interesting item that's on there because, and it really reflects how important it was for us to have a multidisciplinary community of practice. So when the surgeons were talking about it in front of the pathologists and the radiologists, we were like, we don't need to know our synoptic report. Like nobody reads our reports. Like, why would we do that? And actually it was the pathologist and the radiologist that said, hey, like we're doing our reports in a synoptic report. So like you should do them in a synoptic report. And they were saying it's really important for us. We actually do read your notes because, if there's a complication and we're doing a CT scan, we actually do try to look at your notes. And and so the surgeons were like, really? And so, if it was just a bunch of surgeons in the room, this wouldn't have been an item on our indicator list, but having that multidisciplinary community of practice, I think, was quite important. And the other thing about these indicators is they did have a little bit of a more multidisciplinary feel than just sort of surgery. That was the first thing. The second thing about the MCC presentation, it was pretty interesting. Two sites were doing routine presentation of rectal cancer at MCC, and the other centers weren't. And we had a large discussion about, how this would not be possible. There's no way we're going to do it. We're too busy, And so, there was a lot of debate about whether we should keep this item or not. So I just wanted to bring this up because I'm going to get back to it sort of in the audit and feedback part of the results section. But it wasn't sort of all like easy peasy, like everybody's going to do this when we started this project. And things really sort of progressed after we started, but there was a lot of discussion around this one. We also in the workshop had all of the groups tell us, like, what are you doing now? What are some things you're doing at your site that are working really well that might help us with the uptake and data capture of these indicators? And we, basically from the group, we selected the MCC synoptic report from McGill, the radiation oncology peer review checklist from Hamilton, the Cancer Care Ontario MRI synoptic report, and the College of the American Pathologists or CAP checklist for pathology. And basically, after we picked the indicators and picked these sort of tools, we just said for each team at each site, go back to your place. You're responsible for implementing it any way that works at your place. Like if you want to do electronic reports, you can. If you want to do handwritten reports, you can. Whatever fits your local needs and your workflows, you can do that. And so we were pretty flexible about how people implemented this and selected and sort of chose to abstract their indicators. So again, the KT interventions that we talked about at first was just the community of practice itself was a KT intervention. And then we used audit and feedback. So every 3 months, everybody got a report. They could see their results against everybody else's results, and they knew how they were doing against their peers. And it really did promote a lot of healthy competition between our groups, I have to say. We had a phone conference after each round of audit and feedback with the community of practice. And at that time, we all looked at each other's results and we gave each other sort of feedback, and we encouraged, each other to sort of identify the gaps at each center because they were different at each site, and then sort of helped each other to develop local strategies to close the gaps. So during the recruitment phase, we recruited patients with stage 1 to 3 rectal cancer who were undergoing TME surgery at the participating centers. And the primary study outcome was the uptake of the 12 selected process indicators over the 2-year recruitment period. And the secondary outcomes were positive CRM, local recurrence, disease-free survival, and overall survival. The other thing that was a little bit anxiety-provoking is that CPAC really sort of required as part of this project that we had patient engagement incorporated into the project. And I have to say this was a really new experience for me. And it created a lot of anxiety about how am I going to, or how are we going to get the patients and physicians to interact and engage with one another in a meaningful, sort of an effective way. And so we had planned to have 2 interactive sessions, and really the goal of that was to try to figure out sort of what the important things about the patient experience across the rectal cancer treatment were. So I'm just going to leave it at that, and I'll tell you sort of what we came up with when I talk about the results. So this is sort of how I was feeling when we started the project. There were a lot of moving parts. It was the first time I had sort of been leading or helping to lead sort of a multidisciplinary team, people from different specialties, not just surgery, and sort of outside my own province. So there were a lot of moving parts. There was a lot of stuff going on. And really at a certain point, you just had to trust that your colleagues were actually going to do what you asked them to do. So there was a lot of sort of, a lot of moving parts moving into the project. So basically, we recruited 645 patients over the 2-year period. Again, it was quite a homogeneous group. They were all stage 1 to 3 rectal cancer and all had TME surgery. The mean age of the patients was, 60, was it? Oh, sorry, I can't see it. Let me just see. I think it was around 60. Is that what it says? Okay. And about 60% of the patients were male. This is the breakdown of the patients that were recruited from each of the 8 sites. And as you can see, most of the tumors were low to mid rectal cancer. About half of the patients received chemoradiotherapy. 71% had restorative surgery, and 60% of the cases were done laparoscopically. And just in terms of staging, most of the patients, there's a pretty even split between stage 1 and then stage 2 and stage 3 patients, and most of the T categories were T2 and T3. So I'm sorry that this is a really busy slide, and I'm going to try to explain it, but these are the results. So, it's always sort of a little unsettling when one slide in your whole presentation took about 3 years to complete. But anyways, these are the indicators down on the sort of far column. And these are sort of the overall results. So this is sort of over the whole study period, what the uptake of the indicators was. And you can see that it ranged from about a low of 20% with the radiation oncology checklist, and was at a high of about 95% with pre-treatment CT, chest, abdomen, pelvis. And, you know, we had a lot of problems, as you can see, with the radiation. We had 2 radiation oncology type indicators, and you can see that none of the centers were really able to sort of improve over time with these 2. And I think actually that things were happening. It's just that we had a lot of time trying to abstract that data, that the radiation oncologists have their data in a different database, and it became very difficult to access it. So I think things were happening, but we certainly weren't able to capture that. And then what you can see I've highlighted in green, the 6 process indicators highlighted in green were the indicators that actually showed some improvement over time. So here you can see at time 1 as a group, we were at 28% for presentation of MCC, and at time 7, we had increased to 70%. So you can see that for most of these items that they've improved pretty significantly over time. And then there were two indicators, especially like CT chest, that they were over 80% and stayed over 80%. So it was sort of hard to show significant improvement over time. And that was CT chest, abdomen, pelvis, and the MRI report, or pre-op MRI, which was at 85% and stayed above 80 over time. We also looked at pathologic outcomes, and, you know, over time, we didn't see any change in positive CRM rate, although it was quite reasonable and good. Positive distal margin rate and incomplete TME rate. We did see a decrease in sort of the inadequate lymph node retrieval over time. And this sort of led to us, I would say, a sort of maybe improvement in composite outcome. And our composite outcome included negative CRM, negative distal margin, complete TME, and over 12 lymph nodes retrieved. So overall, like with this, with our process indicators, we had good sort of oncological results in our patient group. So, you know, I thought when I first looked at these results, hey, this is great. 6 indicators improved, 2 were above 80, like the lymph node retrieval improved. So, hey, this is great, you know, like easy peasy, done, slam dunk, quality improvement, success. And then I sort of started thinking like, so what does this actually mean? Like, what does it mean? And it became a little bit harder because when you do quality improvement, you set a target, and if you meet the target, it's successful. But, you know, when we don't have a defined metric or standard for quality improvement, it's sort of hard. Is 10% good? Is 20% good? You know, it's very hard to know what it means and what the impact is. And, you know, it's also hard to know if these processes really were associated with improvements in patient outcomes or outcomes. So I did what everybody did. I did like a run chart, like everybody tells you in quality improvement, and this didn't really help me answer my question or get me any closer to what I was trying to figure out. And then, you know, I basically looked at the other literature that was out there. And, you know, I was surprised there were not very many other studies. So these are 3 other studies, from the Netherlands, Florida, and Spain. All of them used audit and feedback to try to improve uptake of process indicators. And the process indicators that all of these studies had in common with CPAC are sort of listed in the far column. And, you know, basically, when you look at our CPAC, our change from baseline, and you look at it compared to the Netherlands, which was really the biggest, it was a population database that they looked at, you know, our results were fairly similar. And then the Florida and Spain studies were before-after studies with fewer patients. But, you know, we were all sort of in the same range of sort of what the baseline change was, and the results were fairly similar. And, you know, it was still from this hard to tell, like, what is like clinically important change. And the Cochrane collaboration has actually done a study looking at audit and feedback, and they've seen in randomized control trials that it usually does increase outcomes by about 17%, from 1 to 17%. So they sort of felt that any change from 1 to 17%, was reasonable, but 17% is sort of where we would sort of expect things to be I think, clinically important. And then I went and spoke to Marko Simonovic, and I think that he's really one of the leaders in knowledge translation and quality in Canada. And he's published a lot of work, and he's done a lot of work in Ontario. Probably about, 15 years ago, he did a randomized control trial where he had very high intensity knowledge translation interventions where expert surgeons would go and operate with another surgeon and do TME surgery and they'd have workshops and they'd do lots of stuff. So it was very intense. And what he found when he did that randomized control trial was that there was no difference in patient outcomes. There was no difference in local recurrence, no difference in survival in the high intensity compared to the low intensity group. And this is a second study that he's done more recently. And again, he had a very high intensity group in sort of one of two geographic regions in our province, and compared it to 12 other geographic regions that did not have this high intensity knowledge translation. And what he really found, so here he looked for the two indicators, pre-op MRI and pre-op radiation. You can see here, this is the high intensity group, this solid red line, and this is the low intensity group, this solid red line. So we found no difference in the uptake of preoperative MRI with high intensity sort of KT. And same thing with the pre-op radiation, that, there was no difference between the high intensity and low intensity group. And not surprisingly, there was not much difference in patient outcomes either when he looked at patient outcomes between the groups. So I think that this is really important. So his sort of feeling is that, maybe the interventions aren't working all that well. And somehow the knowledge is getting diffused to the low intensity group by mechanisms that we don't really understand. And to put so much energy and funding into sort of these high intensity KT interventions may not be the right way to go. And so the sort of new sort of thinking about things is, should we sort of think a little bit more about the way they do it sort of in the airplane industry and put a safety lens on it, and actually look at the sort of positive events or the adverse events. So find those adverse events. And then what Marko has recently has done that in one of our LINs. And he's looked at positive margins. And basically, can you break those down into preventable and non-preventable events? And in the preventable events, can you find system level reasons for why this might be happening? And I think I think there's something to it because, in Ontario, our local recurrence rate across the province has been about 7% for 20 years. Like, we haven't been able to decrease that at all. And I think all the KT interventions and things aren't really changing that. So this is, I think, an interesting concept. Can we sort of learn from our errors, or were there errors, or were there no errors? And what could we do to try to sort of decrease our local recurrence rates? So this is sort of a new sort of thought about quality and how we should do it. So in terms of evaluating success, I've talked a little bit about quality improvement and sort of what sort of our success was. I think the other thing that we did that I think was actually successful, and we did it not knowing, is that when we pick the tools to implement sort of like the MRI synoptic report or, the MCC synoptic report, or doing MRI. They're sort of things, or presentation at MCC. They're sort of things that once you start doing, it's hard to stop doing. And so I think that we didn't really plan for that sustainability, but I think there was sort of a built-in sustainability by the way that the things that we picked. So I think that that was one interesting thing that we hadn't anticipated when we started the study. The other thing is, I just wanted to talk a little bit again about the audit and feedback. So this is the specific data for MCC presentation, and I wanted to show it, because there was so much pushback at the start of the study. But I actually really think, my belief now is that audit and feedback is it's quite useful. It promotes a lot of healthy competition between groups, and it's actually a pretty good way of changing physician behavior. So you'll see here, there were 2 sites again that I said were at 100% of presentation. And you can see there was 2 sites in green. There were like a couple of sites that were saying like, no way, we're never going to do this, forget it, like it's impossible, and you can see that all of these groups, like these 4 groups, went up to 100%, so they really incorporated this. And actually, one of the groups that gave the most pushback, they basically said they love MCC and they're never going to get rid of it after that. So, that in itself, I think, is a really big success story. And so I think the audit and feedback was really important to sort of improve our results as well. The other thing that I think we sort of had planned for, but I don't think that I wasn't sure how it was going to work, is that somehow as a community of practice, we really gelled, like we really got together, we really helped one another, and everybody really did a lot of work and put in a lot of effort. And I think it was because it was something that people believed in, and they wanted to do things that would make things better for their patients. And because of our community of practice, and because we had now some standardized processes of care across 8 centers across Canada, we were able, it was like a platform to sort of apply for grants, and we were very successful getting grants. So we have gotten 3 CIHR grants as a community of practice. And, having that standardized sort of processes of care, having a group has really made a difference, in being able to capture those grants. And I think as a community of practice, we've really contributed a lot to the way we think about rectal cancer across Canada. And, the first study, and I'm just going to briefly talk about the studies that we've done as a community of practice and the contributions, but the first 2 are Quicksilver and the non-operative management study. So Quicksilver was a study to look at whether we could sort of safely omit radiotherapy in well-selected patients with MRI. And we looked at patients with primary rectal cancer. They had staging. They were presented at MCC. And if on MRI, they had a good prognosis rectal cancer tumor, meaning that the distance to the mesorectal fascia was greater than 1 millimeter, they were T2 teeth or early T3 with less than 5 millimeters of extramural depth of invasion, absent for EMVI and NET category. So if they met that criteria, they went to primary surgery, when a lot of times the standard of care for these patients would be to have chemoradiotherapy before surgery. And I'm just going to quickly go over, but the results of this study, when we look at the stage 2 and stage 3 patients at 2 years, and these are all patients that would have gotten preoperative chemoradiotherapy, in standard of care, we can see that we had very good oncologic results with only 1 local recurrence at 2 years, and very good sort of overall and disease-free survival rates. And I think the most important thing here is that only 50% of our patients got any kind of adjuvant treatment with great oncologic outcomes, and really only 8% of patients got post-operative chemoradiotherapy. So we were able to show that we were able to safely omit radiation in these patients, and hopefully, because of the omitting the radiation, patients will have a better quality of life in terms of their bowel and sexual function. So the conclusions from our Quicksilver study were that we had excellent oncologic results with primary surgery. Thank you. Thank you. Yeah. No, it's great. Thanks. Again, 50% of our stage 2 and stage 3 patients avoided any kind of adjuvant therapy, with only 8% receiving radiotherapy. And the other thing that we were able to do, because there was no downstaging with radiotherapy, we could compare sort of our MRI results to our surgery, our pathologic results, and see how well we did with MRI. And what we found was that we did overstage lymph nodes a lot in this trial, even though we had a very specific protocol and GI radiologists. And that has a lot of implications for TNT and overtreatment. So I think that was a really important contribution that we've made. And same thing with the non-operative management study. This is a study where we're taking locally advanced rectal cancer patients with low rectal cancer, and we're giving them chemoradiotherapy and seeing if they have a complete response to chemotherapy. And if they do, the standard of care would be to operate. But in these patients, we're actually watching them to see if we can safely watch them and cure them of their cancer without having surgery. Sorry about that. And we've had excellent interim results. Our target is about 90 patients. We have about 75 patients recruited now. Our local regrowth rate is 12.5%. And all of our local regrowths have happened within 12 months. We've had 100% salvage rate with acceptable pathologic outcomes. But one of the things we found in our study, which I think is a new contribution, is that really when we've had salvage surgery, we've asked the surgeons before the study starts whether the patient needs a definite LAR, an LAR probable APR, or an definite APR. And what we found in all of our patients that need salvage surgery, they all at the start were, the surgeons reported they were a definite LAR, and they've all had an APR. So we've really found that, likely if you have a local regrowth, you have an increased risk of needing an APR. And I think that's an important contribution as well. It's a highly select group of patients, but I think that we've been able to show that we can do this safely. Okay, and the last thing that I wanted to talk about was the patient engagement. So what we did to sort of make it fun for everybody was we played a game of Family Feud. And the night before, we had the patients come to a dinner, and we had them sort of plot out what the 10 most important things were in their experience of their rectal cancer care. And then the next day, we had the patients present or sort of play Family Feud with the physicians. So all the physicians, we were on teams, and we had to try to guess like the top 10 items that the patients told us. It was quite competitive, I have to say. And the surgeons, or the community of practice, with a lot of coaching, we got about 6 out of 10 of the patients' top sort of items. So I'll just give you like 5 seconds, but just think what you think maybe the top 3 things that the patients may have said were the most important things about their sort of whole rectal cancer care experience. Okay, so these are them. And I'm not going to read them all. But I think the most striking thing about these 10 items were they're all revolve around communication, physician communication, and sort of access to care. So after the game of Family Feud, the sort of community of practice got to ask the patients, like, why are these your top 10? Like, why isn't like having a great surgeon one of your top list? Or why isn't like pain management sort of way up there? And the patient said, like, you're right, those things were important, but they didn't make the top 10. Like, these are the top 10. So I think one of the biggest things sort of is that came up was the stoma care for sure, but all of the other things were really around communication. So I think that was a real these weren't the top 10 things that I guessed. So it was really eye-opening to me. And it really showed me how important it was to engage patients. So this was something that I wasn't too keen about at the start of the study, but I learned a lot about, and I have to say, appreciate it and enjoy it a lot more now. The other funny thing was we had, as a second part of the day, we had the patients have lunch with the community of practice. And it was really funny because the radiologist and the pathologist loved it. They were like, oh my God, like the patients are like so like appreciative and like they're so positive. And it was pretty funny because the surgeons were like, yeah, like, but it was again, it was sort of like that was their favorite part of the whole meeting, having lunch with the patients. So it was fun. So. And I just want to show you, so, we got evaluation from the patients as well. And, I think that one of the other things that was really important in this is that, a lot of times you do patient engagement, and it's just a group of patients like doing stuff together. And I think what we did was having them interact with the community of practice, that they really found that meaningful. So I'm not going to read all the quotes, but I'm going to read the last two. As a patient, I'm grateful we were given this opportunity to present our views to professionals, not just other groups of patients. We are actually being heard by those who could possibly make and implement changes to better the hospital system, to better the patient experience, and also to better the doctor's experience with the patient as well. It's not us and you, it's we. The way we will move forward is if we all stay connected to the process. I see this as the beginning. I encourage everyone to stay in it. This is a journey moving it forward. And I have to say, as a result of all this patient engagement, one of the other themes that came out was they felt very abandoned after they got discharged from the hospital, that they went home like they didn't know what was normal, what wasn't normal. And there was a lot of anxiety around that. And I think that I'm a pretty good communicator, but, and how many thousand follow-up appointments have I done, but like, they've never told me that. Like, I've never picked up on that they were anxious for the first week after they went home. I thought once they got home, everything's fine. You're good. Nothing bad's going to happen to you. And so it was completely off my radar, actually. And they said, well, when we show up at 4 weeks after your clinic, like, it's over. So why would we tell you that? Okay. So what that led to was another project that we did called Home to Stay. And I think, McGill's doing that already. You were a little bit ahead of us, but, and again, it's a sort of app that we give the patients when they are discharged from the hospital. And it's quite interactive. So they get sort of an email every day. They have to fill out a survey, and anything that sort of comes out sort of unusual, like as an unusual score, they get a phone call. And it basically gives them sort of individually tailored education. If they have a high output stoma, this is what you should do. So it sort of helps them sort of self-manage over that week. And, again, this is another really nice story, is that we're able to get a CHR grant sort of to look at the effectiveness of this app in patients, and that this is also being done sort of across Canada. So this is sort of a really nice story of how patient engagement was really successful and quite meaningful in sort of helping patients with their experience. So in summary, I'm biased, but I think this project was pretty successful. I think we learned a lot of things as we went along. And, I think for me, the community of practice was probably sort of the most meaningful. And now that we've standardized sort of our care, our processes of care across our centers, so we're able to sort of pivot and sort of, if we have grant ideas, we've been very successful at grant capture. I think, again, we didn't realize this, but we picked some items that sort of increase the sustainability. And so, like, once you start MCC, it's hard to stop it. Once you start an MRI synoptic report, it's hard to stop it. They're not all perfect, but, it's hard to stop once you've started. And I think the other really successful thing for me was the patient engagement, and was very new. I was not very happy about the fact that CPAC like sort of required us to do it, but it again ended up being one of the favorite things of a lot of the community of practice members. And again, evaluating success is quite challenging. Again, there's no standardized metrics or outcomes, whether we should be looking at processes of care or whether we should be trying to decrease local recurrence. It's hard to know which way we should go. And you can't just assume that if you improve the processes of care, the outcomes will be improved. Although that's sort of what our thinking was when we started this project, that, hey, if we can improve these process indicators, like we're going to fix it and we don't need to even measure the outcomes because we know that that happens, but I don't think you can assume that. And then I think the other important thing is that the high intensity KT interventions to improve processes haven't really been shown to improve outcomes in randomized control trials in rectal cancer. And so we need to start thinking about methods to better link our processes and outcomes and improve them. And I think, that safety perspective, looking at the adverse events and trying to prevent the ones that are preventable is sort of a good way to be thinking about it. So I'd just like to thank everybody for being here today. I also just want to say that it takes a village really to do these projects. And I really have to say, like, we've had a really strong group of surgeons across Canada who have really made all of this happen. And I just like to also acknowledge them. And Sender has been sort of the lead person here at McGill, and I really appreciate all of your program participating and all of the work that you've done to help with this as well. So thank you.
Thank you, Dr. Kennedy, for a great talk. I think the most important thing that came out of your talk was patient engagement and how necessary it is and how much we actually have ignored it. But I think more and more studies are showing that it's quite necessary. And I think we're all going to have to incorporate this in our care of our rectal cancer patients. I'll entertain any questions that anyone may have. No questions. Okay. So, so in honor, oh, sorry.
Yeah, I mean, I think it's a great question. I'm not sure I have a great answer for you. But I think that, when you talk to there's a different way of talking to the administration than we would talk to one another. And I think that when you talk to the administration, it's a little bit about patient experience. So you can talk about patient experience, but you also have to have a business case about how could this save money? Why is this going to improve the patient experience and save money or be cost neutral? That kind of, so it's a different way of talking to them, and I think that, the other thing is, what I found is if you have an idea, it's good if you can get other people to sort of like engage with it. And usually, if it's a good idea, like there's going to be, if you get one or two people that are saying, yes, I'm going to do it, you have to sort of, the people that are like, I'm never going to do that, you just have to sort of ignore them and go with it. Because, often those people will join in after they see that it's working. So, and I would just start small, and sort of see how it goes. I don't know, Caroline, do you have any comments about talking to administration or?
It's it's very interesting. It's always very interesting to try and get your point across, because admins usually have their own trajectory and they don't really want to see your point of view. So
it doesn't always align with what you think. should be happening. So, and it usually doesn't happen at one meeting. There's usually multiple meetings until something might happen. So be persistent.
Any other questions? Okay, then, so as part of our thanks in having you as our very successful visiting professor, we have a little plaque for you where we're grateful for you for being the 6th annual Gordon Professor. And as well, we have some McGill souvenirs to give you. A scarf,
Nice.
we have a pen,
Wow.
we have a speaker.
I'm not gonna be able to fit this all
Yeah,
in my
that's
suitcase.
Yo, that's why you have the McGill. That's why you have the McGill bag.
Nice.
And we have something else that I haven't opened, but you can open it and let me know.
Awesome.
And we have a carry bag,
Nice.
so that'll make
Thank
it
you so much. Well, thank you very much. I really appreciated being here and I had a really fun time. So thank you.
Thank you.